Recording. Good morning, everybody. I am Osama Tawfiq, the current president of the Society of Egyptian Pathologists in North America, and I welcome you to another outstanding lecture by one of our colleagues, Dr. Desouki. I'm also the chair of pathology at St. Luke's Health System in Kansas City. Before introducing our distinguished speaker, I would like to take a couple of minutes to remind you about a few housekeeping items before we start. Please mute your speakers and turn off your videos. Questions will be sent either through the chat box found on the right of your screen, on the bottom right of your screen, or in person if time allows. I, the moderator, will try to share them with the speaker at the end of his talk. The lecture is recorded and will be uploaded on the Society's website and on YouTube channel for your convenience and further as references. Please make sure and tell the other colleagues to join through the Zoom app and not from Microsoft Teams. You will not be able to attend the meeting otherwise. We definitely appreciate your feedback to improve our experience, your comments and interest in certain topics that you would like us to cover in the future is very appreciated. One amazing final thing that I would like to share with you is we are in the process of getting the meetings approved for CME credits. I just recently got approval from our Associate Dean for Education, and we start giving credit for the upcoming lectures next month. Now to the introduction of Dr. Desouki, my dear friend and colleague. Dr. Desouki is a professor of oncology, pathology, and gynecology at the Department of Pathology and Gynecology at the Roswell Park Comprehensive Cancer Center in Buffalo, New York. He is also the Breast and GYN Oncology Fellowship Program. Before his current position as the Chief of GYN Pathology at Roswell Park, he served as the Chief GYN Pathology at Vanderbilt University. Dr. Desouki is an MD, got his master's and PhD from the Faculty of Medicine at Cairo University. He later moved to the US, where he received his AP and CP training at the Medical University of South Carolina. This was followed by Breast and GYN Pathology Fellowship at the University of Pittsburgh in Pittsburgh, Pennsylvania. Dr. Desouki is board certified in anatomic and clinical pathology by the American Board of Pathology. He is interested in education, as you will see in a minute, and teaching with multiple teaching awards from Roswell Park at the University of Buffalo. He authored more than 100 publications, books, and book chapters in peer-reviewed journals, and more than 100 presentations at national and international meetings. His title of his presentation is Endometrial Clear Cell Carcinoma. Dr. Desouki, welcome and thank you for allowing us to hear your wonderful presentation.
Thank you, Dr. Tawfiq, very much. I thank you for inviting me to this great group of pathologists in the North America, in Egypt, and everywhere in the world, and we are proud of the progress the Egyptians made everywhere in every field of the medicine. And the talk, as Dr. Osama mentioned, it is about the endometrial clear cell carcinoma. And I have no conflict of interest, unfortunately, and nothing to disclose. So I'm earning nothing from this presentation. And again, I want to thank Dr. Osama Tawfi. He is doing a great, excellent job for this, to structure this from scratch, and created this, the Society of Egyptian Pathologists in North America. And we have the website here. You can go, guys, to the website to know what we are doing. And our main mission is, as Dr. Osama mentioned, is just to spread the education and the clinical practice. And we have many activities for the pathologists in the Middle East and everywhere. And also, I want to thank the Ministry of Health and Population in Egypt for spreading the word and supporting us in this work. With no further views, this is the Buffalo here. Start to have the snow. If I look outside my window here, I have the snow everywhere except in the streets, which has been cleaned. And this is the very famous Niagara Falls. The people comes to visit the Niagara Falls from everywhere. And the outlines of the lecture today is about the morphology of the endometrial clear cell carcinoma. And at the end of the talk, I will have one slide only or so about the immunoprofile of endometrial clear cell carcinoma. In the old days, when I say old days, maybe like 15 years ago or so, the clear cell carcinoma diagnosis is based mainly on the negative everything, negative ER, negative PR, negative PAX, negative, a lot of negatives, which is sometimes is not good enough for us. We need something positive, then we can call this is positive for this marker or so. And I will talk about this, as I said at the end of the lecture, about the immunoprofile of clear cell carcinoma. I am very interested in the subject of clear cell carcinoma in general, especially the endometrial clear cell carcinoma. And this is, I think, this is one of the phenomenal paper published about the morphology of the endometrial clear cell carcinoma. We did review multiple institutions. As you can see, the list here have at least one pathologist from each of those institutions to identify 50 cases with high concordance of agreement among us to call this is clear cell carcinoma. So I don't want to take more minutes to describe how can we selected those 50 rigorously classified cases and how can we reach consensus among those cases. And when you see there is this publication, which is like 2 years prior to our publication, which is characterized the morphology of clear cell carcinoma in the ovary, and they studied 155 cases, and we extrapolate most of our findings of clear cell carcinoma of the endometrium from the clear cell carcinoma of the adnexa or the ovary. And you can say, why not? It is a clear cell carcinoma which could be similar. Yes, could be similar, could be different. And if you apply this to the serous carcinomas, for example, we do have differences in serous carcinomas. I'm talking about the high-grade serous carcinoma in the ovary and the serous carcinoma of the endometrium. And serous carcinomas of the endometrium, we don't grade these tumors because all the serous carcinomas in the endometrium are high grade by definition. But when you go to the adnexa or the ovary, the high grade serous carcinomas, we have high grade serous carcinoma and the low grade serous carcinoma. And even at the immunoprofile level, at the serous carcinoma. So we said, why we're not doing this also for clear cell carcinoma in the endometrium? If you look at the endometrial clear cell carcinoma, it is uncommon histotype. And there is a lot of inter-observer diagnostic variability, and it tend us among the pathologists to over-diagnose this. When we see features of the clear cell carcinoma, sometimes I saw that the pathologist inclined to just say it is clear cell carcinoma, which may be not. And don't forget, many times the serous carcinoma simulate exactly the morphology I am going to describe today for the clear cell carcinoma. So we are trying to apply features of ovarian clear cell carcinoma in diagnosing the endometrial counterpart of this entity. First, when you look at the architecture, and we are a pathologist, histopathologists, we look at the architecture and at the cellular level. So the architecture gives you an idea, and some of us like to see architecture and diagnose. Some of us like to go to the high power of the microscope to see more details and so forth. And it is better to have like combination of both, to look at the architecture, then you go to see the cellular details to reach the correct diagnosis. So the architecture of the clear cell carcinomas, we have three main architectural types. The first is what we call the tubulocystic pattern. And in this publication for our work, we classify the tubulocystic carcinoma into two subtypes. The first is glandular, and the second is cystic. So the glandular or the tubules and the cystic, like we differentiate, and I'm going to tell you how can we differentiate between those two. So this is the tubulocystic. You find some tubules or some glands, if you will, and some bigger glands, which are forming cystic formation. So this is the tubulocystic pattern. The second pattern is the papillary type, and you don't forget the serous carcinomas, because this is our main differential diagnosis. Is it serous carcinoma or clear cell carcinoma? So the old name of the serous carcinoma, it's called papillary serous cystadenocarcinoma. Then we dropped this papillary because a good fraction of serous carcinomas are not papillary at all. Sometimes glandular, sometimes solid, and so forth. So we dropped the papillary. Then we dropped the adeno, and so forth. Now the name of the serous carcinoma is just a serous carcinoma. So this papillary type of clear cell carcinoma is another architectural pattern, something like that. Sometimes you have small papillae, sometimes you have large papillae, and I'm going to describe this in the next slides. The third pattern is the solid pattern of clear cell carcinoma. The cells grow in sheets of cells, sometimes clear and sometimes not clear, as I'm going to describe. So this is the architecture. The second is the cytologic features at the cellular level. So we go to see the cell shape. Or the cells are polygonal or columnar, cuboidal, flat, hobnailing. So those are the cell shape. The second, we look at the cytoplasm of the cells. When we call clear cell carcinomas, not all the cells are clear. Sometimes even we will see some pure cases of all the cells eosinophilic, but still the name is applied for clear cell carcinoma. Then we look for the nuclei, how stratified they are. Stratified means you have multiple layers of cells surrounding the papillae or surrounding in the lumen of the glands and so forth. And we look for the grade of the nuclei. And one of the cytologic features is go to count the mitotic figures. So those are the two main subjects I'm going to talk about today, the architecture and the cytologic features. And when I show slides for the architecture, definitely I'm going to talk about the cytologic features because the cells are there already in the picture, and the reverse is true. When I'm talking about the cytologic features, I will show you also the architectural pattern of this. We do have other features for the clear cell carcinoma of the endometrium. We look at the stroma surrounding the tumor or in the fibrovascular core. So when we see the stroma, what we are looking for? We look for the hyalinization, which is a characteristic feature of clear cell carcinoma. We look for fibrosis, and we look for the inflammation in the stroma. The second, samoma bodies, which is a common entity in the adnexal tumors, but we do have also samoma bodies in the clear cell carcinomas of the endometrium. The third other features we are looking for is the hyaline and the targetoid bodies, and then the squamous differentiation, if any. With no further use, we are going to describe one of those. So the first of the architecture is the tubulocystic, and as I said, we did divide those into two subtypes. The first is the tubules, we call them glands, and to call it glandular, it should be less than or equal to 0.1 millimeter in the lumen diameter. Definitely, we are not going to measure the lumen diameter, but you can just by eyeballing the tumor, if they are small, so call it glandular. If it's larger or large, we call it cystic, which doesn't matter at the end. It is at the end of the day, it is just a tubulocystic architectural pattern. But this is the definition we did apply for this publication. So the cystic, larger spaces greater than 0.1 millimeter in the lumen diameter. If we talk about the tubular or the glandular pattern, those are rounded glands, irregular or compressed glands. Sometimes you think they are solid, but if you look more careful, as I am going to show you some of the pictures now, so those glands could be compressed if you have overgrowth of the stroma component. Sometimes the glands are very confluent, back-to-back glands, and sometimes they are spaced out, what we call non-confluent pattern. Then we have eosinophilic, amphiphilic, luminal contents in some of those glands, and sometimes we don't have any luminal secretions or luminal contents. And intraglandular papillations, and there is no diffuse stratifications in those cases. When I'm talking about stratification, I mean that more than three layers of cells in the glands or the tubules. So the cytologic features of this, of the cells itself lining those tubules or lining the glands. The clear cell carcinomas of the endometrium is characterized by monomorphism. The cells are more or less equal to each others because as I said in the beginning, our main differential diagnosis is the serous carcinoma. And most nuclei display two-fold variation in size and shape, what we call grade 2 nuclei. I'm going to describe this. And when you look at the cytologic features of this, you are going to see the hobnailing. Hobnailing means what? Means the nuclei protruding to the lumen of the cell instead of sitting at the base of the cell, and which is normal. If you look at any like the endometrial glands, you will find the nuclei based on the base, located at the base. When it starts the nuclei to move from the base toward the middle or toward the periphery or the luminal aspect of the cells, we call this hobnailing. Then the cells themselves could be flat or low-cuboidal or polygonal cells. You look at the cytoplasm, as I mentioned before, either eosinophilic and or clear cytoplasm. The mitotic figures usually in the glandular pattern is very low mitotic figures. Sometimes you look, and I'm going to show you the numbers of this. Sometimes you find zero mitotic figures if you look carefully in the glands. And the inconspicuous nucleoli. So the features, usually the cytologic features of the clear cell carcinoma at the lower end of the spectrum of the atypia. Monomorphism, just variation in the size, not that much, just a two-fold variation and so forth. And the mitotic count is low and the nucleoli are not that apparent in this. Look at this here. This is non-confluent growth pattern here of these glands. The small ones, you can consider them glands, and the bigger ones, you can call them cystic pattern, if you will. Or you just call it tubulocystic pattern, and those are separated by the stroma in between. Look at the lining cells here. You will not see stratification. Most of those spaces, either glands or cystic spaces, lined with one layer of cells. And if you can just see this, for example, this nucleus here, it is going toward the luminal aspect of the cell. We have some calcifications here. I'm going to describe this. So this is glandular pattern of clear cell carcinoma with low stratification. And even at this power, you can't appreciate any mitosis. You can't appreciate stratification. And if you look carefully, you may find some clearing of the cytoplasm here. And because of that, the name of clear cell carcinoma came from. Look at this case here. This is a confluent glandular pattern. Small glands here and there and everywhere. And you have some cystic spaces also. Look at the stratification. There is no almost stratification. One layer of cells lining this. Look at the hobnailing. The nuclei try to jump in the lumen of the cells and try to jump actually in the lumen of the gland formation. So this is the glandular. More close-up view to show you the cytologic and the architecture at the same time. So the architecture is what? Glandular architecture here. Confluent back-to-back glands or back-to-back tubules. Then you look at the cytologic features, you will find the hobnailing. No much variability in size and shape. The cells are all like equal in size and shape. Maybe there is some prominent nucleoli here, but not a diffuse pattern of prominent nucleoli. So glandular pattern with the cytologic features I described, and we are lucky enough in this case to find some of the clearing. But look at this here at that particular case. Most of the cytoplasm is eosinophilic. And despite that, this is a clear cell carcinoma. More close-up view to show the same as I described. Some of the nuclei definitely still not forming hobnailing. Some of the nuclei still at the middle of the cell or at the base of the cells, and many of them forming this hobnailing or growing toward the luminal aspect of the cell. You will find me repeating the same words, the same and the same and the same again, because this is the cellular features irrespective of the architecture. Is it glandular or cystic or papillary or solid pattern? We do have the same cytologic features. This is again non-confluent growth pattern of glands and cysts here. And the small ones are glands, the big ones are cysts. Sometimes the lumen contains this material of eosinophilic material in the lumen, and all the features I described again you apply here. I will stress on it many times. There is no much stratification, at least in this picture here. There is no much of atypia, and the nuclei are more or less equal in size and shape, and no much mitotic figures in this. Again, this is a compressed pattern of glandular or confluent pattern of glandular proliferation. Some glands here, most of those are glandular patterns. Some of them are cystic spaces with the same cytologic features I described many times before. This is again confluent growth pattern of cells lining those glands and cystic spaces with all the features described before in clear cell carcinoma. And don't be deceived for the if you find no mitosis or you find no much apparent atypia of this is still clear cell carcinoma by the features I described. This is maybe confluent or a little bit non-confluent glandular growth pattern with all the features, the hobnailing and the intraluminal material, eosinophilic material in these cells. And most of the cells here are eosinophilic. So it is no even one clear cell cytoplasm in this particular case. This is more of the clear cell cytoplasm. Most of the cells in this particular case are clear, have clear cytoplasm. Most of them have hobnailing, and there is hyalinized stroma in between this. So this is one of the features described other than the architecture and the cytology, which are the stroma in between. So the stroma is hyalinized, which is a very characteristic features. When you look and you find this hyalinization, it is very difficult to find other tumors with this hyalinization. But as I said, the serous carcinoma could have the same morphology as the case you are seeing now on the screen. This is to show you the stroma of this, the gland's proliferation with clear cytoplasm, and the stroma is full of inflammatory cells. So this is one of the features also we did discuss and we did study in this publication. This is to show you the very rare stratification. Look at this gland here. Some stratification, more than 3 layers of stratification here. As I said, this is a very rare event, but most of the glands and the cystic spaces are lined with just 1 layer or 2 layer. And as I said, we did describe stratification present if there is greater than 3 cell layers, as we see here focally in this focus here of stratification. But the hobnailing is still again, the low mitotic figures is still again in this pattern of clear cell carcinoma. When we did study this, we did study the presence or absence, predominant or focal or minor component. We did classify this based on the percentage of the component. If we have greater than 66%, 2/3, we call this predominant. If it is less than 1/3, less than 33%, we call this minor. And if it is in between from 33% to 66%, we call this significant. You don't have to go to your report and see this is predominance or significant or minor. But this is for the study. For our study, so this is we just classify as such to just describe because this is a research. So we have to go in detail and in depth to do this. So if you find the glandular pattern, the predominant pattern of those 50 cases, I appreciate if everyone mute yourself, please. So mute yourself. Thank you. So if it is present, it is present in any percentage in 42 cases. And the percentage you can very easy get in this publication because we have 50 cases. So multiply in 2, you get the percent. So the 42, 84% of the cases we do have a glandular pattern, which is predominant in 15 cases or 30% of the cases, significant in 12 cases, and the minor in 15 cases. And the absent, there is no single gland in 8 cases or 16% of the cases. So this is the glandular pattern of architecture in the clear cell carcinoma. Then we go to the cystic pattern. We say the cystis looks like glands but larger. We have bigger lumen of this. So we have non-confluent again and the confluent cysts depending on how much stroma in between the cysts. So if you look at the luminal content of those cysts, sometimes you find eosinophilic or amphiphilic luminal contents, and sometimes you find nothing. And you look at the cysts, sometimes we have intracystic papillations, the small papillae arising from the lumen of those cystic or big glands, if you will. And again, there is no nuclear stratification in most of the cases, as I'm going to show you the numbers. So this is like a pure cystic pattern of case. You see, all the spaces are very wide with eosinophilic material, but again and again, the same morphology I described before. I'm not going to repeat this multiple times, but I will do in this case only. So you have here low stratification or no stratification at all. You have the hobnailing, you have the low mitotic figures and so forth in this case here also. If you look at this case in the endometrium, you maybe even miss the clear cell carcinoma, but it is because of the features I just described. Another one case again here with cystic spaces. You see how big the cystic spaces and the intraluminal spaces, and you see the mitotic, the hobnailing of the cells and the very low mitotic figures of this. So this is the cystic pattern of clear cell carcinoma of the endometrium. More and more again to show you the morphology as well as the cytology of the cells of the clear cell carcinoma in this cystic pattern. Big spaces and all the features of cytology in this particular case. Again, to show you the cystic pattern, I show more pictures because you will face this when you see endometrial cases. And the stroma here, you see maybe some hyalinization if you will, and you see big cystic space with no secretion at all. So the secretion in the lumen could be present, could be absent in this cystic pattern of architecture. This is another case here with cystic spaces to the left here, and to the right here there is papillary architecture, and I'm going to describe the papillary architecture in few minutes. So when we did study our cases, the 50 cases of clear cell carcinoma in the endometrium, which is the cystic pattern, it is present in 16 cases, which is 32% of the cases, and it is predominant in 2 cases only, significant in 3 cases, less than 2/3 of the architecture, and minor, less than 1/3 in 11 cases, and absent cysts at all, no single cyst in 34 cases. So most of the cases there is no cyst formation in this, at least in our study cohort. So this is the first architecture. We talked about the tubulocystic, and we did divide them into glandular and cystic pattern according to the size of the diameter of the lumen. Then we move forward to the second pattern, which is the papillary pattern of growth. We did classify this into 2 patterns of papillary: small and round papillae. We call it SRP, small and round, and we have the papillary pattern NOS, not otherwise specified. So something like this, if you have like small papillae, and when we call it small papillae, what is small is small. So this is collection of cells, and we did put a cut off. If you have less than or equal to 25 cells, we call this small round papillae. And greater than 25 cells, this is NOS papillary formation. And again, you are not going to count the cells, they are 25 or not 25. At the end of the day, this is a papillary pattern of clear cell carcinoma. Why we call this, why we show this? Not to confuse this with what? With serous carcinoma, which in most cases of serous carcinomas, they do have papillary pattern. But the cytologic features here are different. You see the hobnailing of the cells here. You see low stratification or no stratification at all, just 1 layer of cells. You see the monotony of the cells. There is no bizarre nuclei and so forth in this particular case here. And the lumen of this also could have some exfoliation of this small papillae. So this is the small round papillae. And if you look at the stroma in this particular case, you have the stroma is hyalinized, which is a feature, soft feature of clear cell carcinoma, and also the stroma in this particular case contains these inflammatory cells. So clear cell carcinoma with a small round papillary architecture of this case. Another case here to show you the small round papillae. Sometimes you do have fibrovascular cores, and many times you don't have fibrovascular cores, what we call micropapillae or small round papillae, if you will. And those small round papillae could be in the lumen of like cystic spaces or could be arising from a big papillae, as we are going to see in the next few pictures. And the cytoplasm, again, the cytoplasm is clear. Some of the cytoplasm is clear, some cytoplasm is eosinophilic, and so forth. And all the cytologic features, again, apply for this papillary pattern of growth. Sometimes you find this long, slim-like papillae with fibrovascular core. And around the papillae, again, you see this papillae completely different from the serous carcinomas. There is no stratification. There is no bizarre nuclei in this. We will find bizarre nuclei for sure. It is not a known feature for the clear cell carcinoma, but it is rare to find this. So papillae, big papillae in OS, and from this, the end of the papillae, there is a small round papillae just sprouting from this. And you see this very big papillae here, very big papillae, then give rise to those bigger papillae or a little bit relatively smaller to this big one. Then at the end of this branching, you will have the small round papillae with all the cytologic features. Another case here within the lumen of what looks like cystic spaces. You do have the nuclei with all the cells with all the features of clear cell carcinoma, including the clearing of the cytoplasm, the hobnailing, and the low mitotic figures and so forth of this small round papillae. Again and again for the same features, small round papillae arising in this morphology. More of the picture to show close-up view for this, and very low mitotic figures. You see here, maybe one mitosis here or two or so, but most of the cells have low mitotic figures. And this is again one of the small papillae arising from big stem papillae, and you have the hyalinized stroma in between this papillae and inside the fibrovascular core of papillae. So both the small round papillae and the conventional NOS papillae with all the features of clear cell carcinoma. And when the tumor invades the myometrium, like here, it took the morphology with it. You see, this is the tumor here, the clear cell carcinoma, small round papillae. And in the myometrial invasion, again, there is also the small round papillae. And we do have here some MoMA bodies in this particular case in the invasion, in the myometrial invasion. More of the same to show you the clearing of the cells, predominant clearing cell, and you start to have some bizarre nuclei in here. Will not make it serous carcinoma, still clear cell carcinoma with all the features of this. And this may be called round papillae, as you are going to see. This hyalinized fibrovascular core is very characteristic in the fibrovascular core of the papillae and also in the small papillae of this architecture. And this is what we call the open tumor rings. Open tumor ring is like a little bit larger papillae, but the cell number still is less than 25. So we call this open tumor rings. What we call this, don't call it in the report, but just to know the pattern. Then when you see this, it is very characteristic for the clear cell carcinoma. This small papillae, but instead of just the lumen, there is no lumen there. There is a lumen there with some secretion, like this case for open tumor rings. More of the same to show you the papillary pattern with conventional NOS papillae and small round papillae in the lumen, as well as at the end of the regular papillae. You see this very big papilla here. And this particular case has some stratification, which is a rare feature of clear cell carcinoma. Again, the cytoplasm is clear, the nuclei looks like each other's, maybe twofold increase in the size and so forth. This looks like fibrotic papillae, okay, but the cells have all the features of clear cell carcinoma. More of the same to show you the patterns of clear cell carcinoma of the endometrium. More of the same papillae, and out for the papillae arise those micropapillae or small round papillae, and some of the cells are still big, bizarre nuclei, but the mitotic figures are low. So when you see the papillae, in our cases, the 50 cases, it is present in 36 of the 36 cases, which may be like 72% of the cases. It is a predominant feature in 14, and it is absent, no papillae at all, small or round or anything in 14 cases, representing 28% of the cases. The last pattern of the clear cell carcinoma in the endometrium is the solid pattern. So this is a sheets, diffuse growth pattern of cells. There is no architectural pattern. There is no papillae or glands or cysts or anything. The cells are the same. The cytology could be eosinophilic, could be clear. And one of the features I did find in this, or we did find in this, is the well-defined cell membranes in most of the cases. Then the nuclear grade are mostly of the solid pattern, higher nuclear grade. So grade 3, which are greater than threefold different in size and shape of the nuclei. Mitotic index in this particular pattern is a little bit high than the other two patterns I described. And we have diffuse, thin, fibrous septi separating the groups of the proliferation. Something like that. And this particular case mostly is eosinophilic, but it is growth pattern. But there is still some clear cells here. Then you have inflammation in the stroma. Then you could say, what what is this? This could be squamous cell carcinoma, and the differential diagnosis could be clear cell carcinoma, could be even serous carcinoma. So all those are in the differential diagnosis, but we do have other features to characterize and to diagnose this as a clear cell carcinoma, as I'm going to describe. So the cells here are just, there is like separated from each others, the inflammation in the stroma, the clearing of the cytoplasm in some of the nuclei, and the eosinophilic pattern in most of the nuclei in this particular case. So this is the solid pattern of clear cell carcinoma. Again, this is one of the pattern. You see the cells are just well separated, respect each others. There's like a membrane in between every cells. But when you look at the big picture of this, there is like septi separating those groups of cells into like nests, if you will. And the cytoplasm in this particular case to the right here are clear cytoplasm. When you look at the left, those are the eosinophilic cytoplasm and some mixed also with clearing of the cells. So this is the solid pattern of clear cell carcinoma. Again and again and again, close-up view to show you the septation, the thin septi separating those solid pattern of growth into groups of cells. And then you go to the cytology itself, you'll find the bizarre nuclei scattered here and there, what we call grade 3 nuclei, and the clearing of the cytoplasm and so forth. More to show you the same of this solid pattern of growth. When we did study the 50 cases, we did find that the solid pattern is present in 27 cases, and it is completely absent in almost half of the cases. There is no solid pattern in 23 out of 50 cases, and constituting the minor component in 11 cases. When I said minor, means then less than third of the pattern. But so the frequency of the architectural pattern I described for the pure, just exclusive pattern only. There is nothing else. When you look at the papillary pattern, we present just the only pattern in 3 cases out of 50. The solid pattern in only, just the only pattern there is 1 case only out of the 50, 2%. Only glandular pattern in 2 cases, only cystic pattern in 0 cases. So from these numbers, you can just guess, because it is mostly we'll find what? We'll find the combination of the patterns as we'll show you here. So when you find, for example, glandular and the papillary pattern in 7 cases, glandular and the papillary and the solid patterns in 12 cases. So the message from this slide is to expect to have a mixed pattern. You will not find only glands. And we are lucky enough to have this, because if everything is solid pattern, so this means what? Sometimes we could misdiagnose these cases. If everything is glandular pattern, we could miss this as an endometrioid carcinoma and so forth. So you will find a mixed pattern of this, but don't call it mixed carcinoma. Don't call it clear cell carcinoma and endometrioid. So it is still clear cell carcinoma with different architectural pattern. So it has some papillae and the glands, some glands and papillae and solid patterns and so forth. But in this study, we did find, you see these zeros, we didn't find papillary and cystic patterns only in 0 and so forth. So from those numbers, you can guess what you are going to get in clear cell carcinomas of the endometrium. And how to grade these tumors? It is, if you look at the CAB checklist, they said, and this is the protocol, the most recent one, they said International Federation, the FIGO grading system applies to endometrioid carcinomas only. All other subtypes are considered high grade. So serous, clear cell carcinoma, carcinosarcomas, all those patterns other than the endometrioid carcinomas, those are high grade. So don't call clear cell carcinoma, high grade. Don't call this. If you call it, this is not the end of the world, because by definition, those are high grade carcinomas of the endometrium. Do we have grading system? Unfortunately, as I said, no. But we do study, we do research study. We have to propose something. So when proposed for ovarian, there is paper from Japan here came. They tried to propose a grading system for the ovarian clear cell carcinomas. They classified into grade A, B, and C, not grade 1, 2, and 3 in this particular paper. So grade 1, they said greater than 90% tubulocystic or papillary pattern. And grade C, at least you have 10%. So 10% or more solid pattern, they classify it as C. And the grade B, those are something in between. So we can't put it here, or you can put it here with solid pattern. So we call this grade B. And this predicts the survival of the ovarian clear cell carcinoma. Is this apply for the clear cell carcinoma of the endometrium? Could be. We did classify our cases also according to this. So in summary of the endometrial clear cell carcinoma architecture, the papillary and the glandular patterns of architecture are the most frequent patterns you will see in the endometrioid clear cell, in the endometrial clear cell carcinoma. The small round papillae is the most common type of papillary pattern, and the solid pattern should be evaluated with other architectural patterns that may be present. Because as I said, if you have pure solid pattern, this is a big, pitfall. You can diagnose this as something else. Papillary glandular, small round papillae if it is papillary pattern. Nuclear grade, we did try to classify this into grade 1, 2, and 3. So grade 1, broad uniformity in the size and shape of the nuclei. Grade 3, severe pleomorphism, greater than or equal to threefold variability in the nuclear shape. And the grade 2 in between, twofold variability in the nuclear shape and size. And something like that. So this all monotony, like twofold greater than the regular cells in this, but we don't have regular cells here. Everything in this particular picture is tumor. So this is grade 1, uniformity of the cells. And this is grade 3. You see how bizarre the nuclei are? But still the cytoplasm is clear and there is some hyalinized fibrovascular stroma and so forth. So grade 3, and I showed you grade 1 and the grade 3. So when we looked at the nuclear pleomorphism in this, predominant nuclear grade 1, 0. Predominant means like greater than 2/3. It is no single case, but most of our cases are grade 2 nuclei. Twofold variation in size and shape, 48 cases, and the grade 3 predominant in 2 cases, but mostly are mixed, grade 1 and 2 and so forth. And when you look at the cell shape, predominant cell lining those glands or lining the papillae mostly are low cuboidal or hobnailing in 49 cases, 100% of the cases. There is no single case in our study with just columnar cells, or there is no single case with only flat cells like this. So 0%. Most of the cells are hobnail, low cuboidal, or polygonal cells. Cytoplasmic tincture, exclusively clear cells. Look at this, very interesting. It is called the clear cell carcinoma. But when you look at exclusive clear cells in 2 cases only, exclusive eosinophilic cells in 5 cases. So both clear and eosinophilic, but the clear is more in 19 cases and the eosinophilic is more in 13 cases and so forth. So don't expect every cell to be clear cells in a clear cell carcinoma. Actually, the reverse is true. Most of the cells will be actually eosinophilic and not clear, as you can see here in these 5 cases out of 50 with just eosinophilic cells. Nuclear stratification greater than cell types, it is diffuse in 0 of the cases and it is absent in 46 cases. Very sporadic, very focal in 3 cases. Mitotic figures, look at this interesting slide here. Mitotic figures, we measure this in 10 high power field. Okay, 0, there is no single mite in 10 high power field in 6 cases. 12% of the cases you don't expect to find any mitosis. Greater than 6 in only 9 cases. So usually the number is like low, like that 1 mitotic figures per 10 high power field in 14 cases or 28% and so forth. Miscellaneous bodies, I described this in the beginning, which is like stromal hyalinization, very characteristic of this clear cell carcinomas of the endometrium and also of the ovary. Hyalinization, Samoma bodies is present in some of the cases. And those hyalin bodies, I did find those are very sometimes helpful. You did find some hyalin bodies, just like globules of hyalin in those bodies here, scattered in between the cells. Is very I see it in very characteristic, but non-specific for clear cell carcinoma. Targetoid bodies, you find some clearing, then something in the center, hyalinized like hyalinized bodies, but a little bit bigger. Targetoid bodies like this. And again, this is one of the cases I have here with the targetoid bodies, and this is the tiger here, so you can see this tigeroid pattern, if you will. Stromal inflammation is common in those cases, and I will show you the numbers right now. And this is also some inflammation in these cells and the hyalinization also. And this is solid pattern. I think I showed you this slide before with the inflammation in this stroma. Squamous differentiation is 0. We did find no squamous differentiation. And this is a good differential point between clear cell carcinoma and endometrioid carcinoma. So the presence of squamous differentiation is a good feature to exclude clear cell carcinoma. Depth of myometrial invasion here, some cases with non-myo invasion 0 in 8 cases, but you find less than 50% in the majority of cases, 21 cases, and greater than 50% in another 20 cases, and unknown for 1 cases. So maybe you say half and half or so. So 20 out of 50 cases greater than 50%, 30 cases less than 50%. Then I will introduce you very quickly. I'm running out of the time here, but the clear cell carcinoma, endometrial intraepithelial carcinoma. This terminology we did identify this. What is this? Endometrial intraepithelial clear cell carcinoma. It is present either in the endometrial surface or inside the glands, very focally in the tumors. And we did not find any single case of just clear cell endometrial intraepithelial carcinoma. So it is, as I said, in the surface or inside the glands. It is isolated from the, what is this? So cells indicated to be associated with invasive malignancy. It is present in our case cohort in 42% of our cohort and isolated from the main malignancy. You will find it somewhere in the surface of the endometrium away from the main tumor. And this is one of the cases here we have, for example, if you look at the surface here, and this is the close-up view, you find the surface endometrium is lined with this clear cells, if you will, with the Hubner-Ealing and the low mitotic figures and all the features I described many, many times in the surface here. So this is one of the endometrial clear cell intraepithelial carcinoma. And this is another case here with intraepithelial clear cell carcinoma. And this particular case, like the intraepithelial carcinoma, is lining the glands. Look at the glandular formation, and this is away from the tumor somewhere. The same features, everything the same, but this is confined to the glandular lining. Another case here with some intraluminal papillation of this. So this is clear cell endometrial intraepithelial carcinoma. So the key features of when you have a case, you wanted to know this is a clear cell carcinoma of no, go to the yes and the no here. So yes, if it is papillary, tubulocystic, and solid, as I described. Polygonal cells, Hubner-Ealing, and low cuboidal cells, no columnar cells. Eosinophilic and clear cytoplasm. Sometimes both are equal, sometimes only eosinophilic, sometimes only clear. And the low mitotic index, except if it is solid pattern. What are the no's? Diffuse nuclear pleomorphism or stratification, most probably you are not dealing with clear cell carcinoma. And diffuse columnar or only flat cells, most probably you are not dealing with clear cell carcinomas, as I showed you. And squamous differentiation, I can assure you are not dealing with clear cell carcinoma if you have squamous differentiation. So when you compare this to FIGO grade 3 endometrioid carcinoma, it is a greater than, we know this is FIGO 3 means greater than 50% solid architectures. The glands of those will be the reverse of the clear cell carcinoma. Tall columnar cells, stratified nuclei, moderate nuclear atypia, and squamous differentiation. So this is, you are not dealing with clear cell carcinoma. If you have those features, you are 99.9% you are dealing with FIGO grade 3 carcinoma. Look at the serous. It is still papillary, solid, and glandular, but the serous differentiation, irregular glands, often with slit-like spaces, budding and exfoliation of the tumor cells, and you have cellular tufts, stratification. You have nuclear, high nuclear grade in diffuse high nuclear grade, and you have atypical mitosis in comparison to the clear cell carcinoma, and usually you have macronucleoli. I promised you guys I am going to give you one slide only for the immunoprofile. What are the positive staining? We are lucky enough to have the Nepsin. So this is positive in most of the cases. And don't forget, this is not 100% of the cases. Most of the cases, maybe 80+% of the cases, you will have the strong Nepsin staining. And you have to be familiar with the Nepsin staining. It is like dirty cytoplasmic staining. And it is almost negative. We did find only 1% of the endometrial serous carcinoma with some Nepsin staining, and it is almost negative in the endometrioid carcinoma grade 3. So the Nepsin staining is the positive. The HNF1 beta, some people like this, some people don't like this, but it is positive in most cases of the clear cell carcinoma. Amacar, another nice staining, positive staining for the clear cell carcinoma. When you look at the P53 aberrant, we have some cases of clear cell carcinoma, you have mutant type of P53 expression. But all the cases of serous carcinoma will have this aberrant type of expression of P53. We have other stains here, but look at the ER of VR. Most of the cases are negative. We do have some cases, definitely, in my experience, maybe around the 10% or so of clear cell carcinoma has either ER or BR or both. So, but you look at the serous carcinoma, mostly are positive for ER. So the negative, all the days, the negative, 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 the ER, BR in clear cell carcinoma. And we do have now a positive, and the positive, which is HNA from beta, Nepsin A, and Amacar for clear cell carcinoma. And I think this is my last slide. And also, I thank you. And this is my email. If you have any question, in this lecture or something else in the GYN or breast pathology, please don't hesitate to contact me at my email. And again, I thank the Society of the Egyptian Pathologists at North America, and I thank the Ministry of Health and Population in Egypt, and I thank my institution, the Roswell Park Cancer Institution, for giving me the opportunity to work there and to have this presentation. Thank you, everyone, and thank you, Dr. Tawfiq, again.
Outstanding lecture, Dr. Desouki. Thank you so much. The floor is open for questions.
I have one question.
Go ahead.
Thank you, Dr. Desouki, for this great lecture. My question is basically about the endometrial intraepithelial carcinoma, the clear cell type. I'm not sure if this is a separate entity from the tumor itself. Can we have this as just intraepithelial component without having an invasive component? And the other question, what is the difference between this and the endometrial carcinoma with no myoinvasive component?
Can you repeat the second question, please?
What is the difference between this and the clear cell carcinoma without myoinvasive component?
Okay, so very good question. So the question about do we have pure cases of clear cell intraepithelial carcinoma? In our study, we don't. So we don't have this single case with just intraepithelial carcinoma. What I assume if you search the literature, you will find some. So the second question is that what is the difference between this and the no myoinvasion? Don't forget, most of the tumors, endometrioid and the serous and the clear cell carcinoma, there is no myometrial invasion. So the features have a proliferation, confluent proliferation in the endometrial lining. A lot, sometimes it is maybe like 5 millimeter thickness or 10 millimeter or maybe more, and there is no invasion at the myometrium. So, and sometimes this is very confusing. We tell the people endometrial carcinoma non-invasive to the myometrium. So is the process everything intraepithelial? It is not. It is not intraepithelial. Intraepithelial only applied for the surface epithelium or isolated glands lining the glands. But excellent question.
Thank you very much.
Sure.
I have one question. What happens when you have, I had a case like that last week, actually, when the predominant background is endometrioid type, and then there are focal clear cell features that are confluent with some, not much hobnailing, actually, and they were mostly confluent. And I did Amacar, I did Napsin A. Those areas were focally positive. How would you report that?
Yeah, excellent question, Dr. Osama. Thank you for this. So, do we have mixed carcinoma of endometrioid and clear? Yes, we do. How often we have this? Very rare, and they're trying to not to make mixed carcinomas. But in those particular case, you have two clones of morphology with immunophenotype of the clear cell carcinoma in the smaller clone or in the bigger clone, and the other clone is dead negative for the markers, especially if you do apply for like two markers, Amacar and the Nepsin A. So for those cases, very rare case, I do call those mixed endometrioid and the clear cell carcinoma. But when you do the stains and everything is negative, so this is usually just some clone of endometrioid carcinoma trying to simulate the clear cell carcinoma. Yes. And we do have in our studies, we do have those cases of endometrioid carcinoma in the endometrioid carcinoma in the uterus. When we have recurrence in the vagina, the recurrence is purely clear cell carcinoma. And we did report those few cases of those. So could be there is some clone there, clear cell carcinoma. And when the tumor recur, usually the tumor recurs the most, the most aggressive pattern which will recur. So this is just make a note of this. Even if the stains are negative, they call it endometrioid carcinoma with focal clear cell features in case in the future there is recurrence of this clear cell carcinoma. Thank you. Any other question?
I have one more if nobody has any. Oh, if
No, I
Maha,
have here. Maha.
go ahead.
Yes.
Maha.
Thank you. Excellent presentation. Thank you so much, Dr. Osama, as well. Can we differentiate like clear cell carcinoma of the ovary from the endometrium, just in case we have synchronous? I don't know how frequent is it, but I'm just thinking like, do they have the same immunoprofile, same morphology, everything? Or there is something which can differentiate, like if it's endometrial?
Excellent question. Thank you very much. As I said in the beginning, when we study this, we try to find some features unique for the endometrial compared to the ovarian. We didn't. Okay, even the staining pattern, the napsin is the same here and there. The amakar is here and there. So we don't have features of this. So when we apply, are those like metastatic tumors coming from the uterus to the ovary, or metastatic tumors coming from the ovary to the uterus and the reverse and so forth, we apply the same features we apply regular for endometrioid carcinoma. As in independent tumors, two independent tumors, we stage both of them as such, or could be metastatic from one tumor to the other. So we apply the same features. If you have, for example, more than 50% myometrial invasion, and there is lymphovascular space invasion, and the tumor, involving both ovaries. So this is most probably a clear cell carcinoma coming from the endometrium to the ovary. Okay, but if you have superficial endometrial clear cell carcinoma not invading anything, or invading less than 50% of the endometrium, no lymphovascular space invasion, and there is another tumor in one ovary or so, I call this independent tumors. And we have publication of this. We try to differentiate between the endometrioid and the adnexal tumor, so you can look for this paper also. But so far, we don't have features morphologic or immunophenotypic to differentiate between both.
There is a time for one more question, please.
Go ahead.
Thank you so much, Dr. Desouki. Yani, as usual, amazing lecture. Yani, I'm used to these great lectures. So, Dr. Desouki, I have a question. If we have this on a biopsy, like the solid pattern, I'm asking because I had a case this week. It was solid pattern. It was, it looks high grade, like there is nuclear pleomorphism, but it didn't fit the serous carcinoma. Like the first time I saw it, I thought it's going to be serous, but with stains, it turned out to be negative.
Excellent.
So I ended up calling it high grade carcinoma and refer for the permanent resection for further classification. طبعا بعد المحاضرة دي I would have done some of the stains for clear cell. بس هي, how far should I go on a biopsy?
And very excellent question, Ma. Thank you for joining us today. And this is interesting. What I am going to do, if I have this, I have like my antenna. First of all, I will think this is serous carcinoma until proved otherwise. So I do the stains, 1 or 2 stains for the clear cell carcinoma, and 1 or 2 stains or so for the serous carcinoma. Then, if this is P53 non-mutant type and P16 not positive, then napsin is positive, I am going to call this clear cell carcinoma. And some even in institution consider this as a critical value. They call the clinicians who have clear cell carcinoma because there is high probability of thromboembolic events for those patients. So the clinicians may give heparin or give whatever they are going to do. So this is to catch this in the biopsy, because between the biopsy and the hysterectomy, you could have 1 month or 2 months, depending on where you are. So it is good to know this is clear cell carcinoma. If you think of clear cell carcinoma, exclude it. If just hit your mind, this solid pattern, some clearing or eosinophilic, low mitotic rate, there is no much bizarre nuclei. And this is, as I said, this could be common in the solid pattern, the bizarre nuclei and everything. Apply the B53 and apply the napsin, at least to those 2 stains, at least. Then napsin positive, B53 non-mutant type, call it clear cell carcinoma, or at least high-grade endometrial carcinoma or Mullerian carcinoma, suspicious for clear cell carcinoma or suggestive of some. So try to announce this is a clear cell carcinoma from the biopsy. Then the clinicians may do something to prevent or to decrease the thromboembolic event of those patients.
I see. Thank you so much, Dr. Desouki. That's very helpful. Thank you.
Thank you.
Okay, well, we managed to finish on time. Thank you again, Dr. Desouki, and thank you guys for your attendance, and see you next month and next New Year. Happy New Year, everybody. Okay.
Thank you again for everyone. Thank you
Same
very
to
much.
you, and thank you very much.